Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to Filibusters in Fine Print, AMJ's public policy podcast. I am Chet Speed, your host, and for the third podcast episode in a row, I am with only one member of the AMGA, what I truly believe is an all-star team, and that is...
Hi everybody, Daryl Drevna, Senior Director of Regulatory Affairs.
And Daryl, this is our third episode in a row.
It is. Let's see if can we stick the landing here?
Three is a charm.
Yeah.
Let's hope so. I do know my guy is, he's yearning for something, something beyond just regulations. Yeah. But my guy, thank you for producing and for sitting with us these three episodes. You're a good man. And good luck in Walt Disney World.
Yeah.
All right. So today, for our final episode, at least for these weeks, we're going to talk about the CMS Medicaid Managed Care State-Directed Payment Proposed Rule, which actually flows directly from the One Big Beautiful Bill Act, which passed last January 4th of 2025, which contained big picture, $1 trillion in cuts to the Medicaid program over 10 years. And a big part of those cuts is the changes to the state-directed payments, which many of our AMGA members count on in their individual states. So just a couple top line points about the SDPs. There is some concern around them, at least from the administration standpoint, because they did rise from almost $100 billion in payments in fiscal year 2024 to almost $150 billion in fiscal year 2026. I think that's the backdrop to why CMS says it wants tighter guardrails around state-directed payments. And what this proposed rule would do in an overarching way is they'd cap these SDPs at 100% of the Medicare rate in expansion states, which is 38, I believe, in the District of Columbia, and then 100% in non-expansion states, which will replace the current commercial rate benchmark, and it'll extend that limit to all SDP payment arrangements, and not just the four service types Congress indicated in that law. So that's the big picture. There are a lot of questions flow from that big picture. So SDPs have grown into a massive part of Medicaid managed care financing. As I mentioned, it's approaching $150 billion in fiscal year 26. What problem does CMS say is trying to solve here?
Sure. And this all stems from the idea that the state-directed payments, which are ways for state Medicaid plans to sort of plus up select providers and make sure they have adequate resources to deliver care, in CMS's view and some of the administration's view, that these are simply, vehicles for waste, fraud, and abuse, right? They're in their thinking that these state-directed payments are structured to financially advantage a small number of providers or let states lean on provider taxes and intergovernmental transfers instead of investing their own general revenue funds into the Medicaid program. So, CMS is thinking you're, directing payments to the subset of providers and you're not bringing in your own dollars. You are, sort of abusing the system to draw down federal matching dollars that you otherwise wouldn't be eligible for. So that's what CMS is trying to solve here. This was addressed in the One Big Beautiful Bill Act, like you mentioned, and this regulation is, implementing that statutory requirement.
Okay. I do believe I've seen CMS officials, maybe even Dr. Oz, talk about state-directed payments as being money laundering. A money laundering scheme because you're putting money in and taking out somewhere else.
They are not shy about their ire for that.
They do not like it in the slightest.
No.
All right, so as we mentioned, the proposal is essentially going to replace the current average commercial rate, which is the current law or regs, ceiling with a Medicare-based payment limit. What does that shift? Why does that shift matter so much to states and providers? I think we all know, but I'd like to hear.
Sure. So this will get into exactly how this works functionally. Since 2024, The de facto state-directed payment ceiling has been the average commercial rate, which is generally well above Medicare rates. And this new limit, like you were saying earlier, is going to cap state-directed payments at 100% of the applicable Medicare rate in expansion states, 110% in non-expansion states. So this is a real dollar reduction for services that are reimbursed, near that average commercial rate.
Which can be in some, you have read in some instances, that's 2 or 3 times Medicare rates.
Right.
So this is a dramatic reduction.
Dramatic cut. If there's no Medicare rate for a particular service, I'm sure that exists somewhere. The fallback rate is the Medicaid state plan rate or a waiver rate, which is likely which is still likely lower still. And then I think depending on your Medicaid exposure, academic medical center, this could mean a real cut to those supplemental payments that are already, layered on top of below cost-based Medicaid rates. So that's a long-winded way of saying this is significantly going to cut and reduce what Medicaid is paying for services. And we're not even touching, we'll talk about this in a later episode, the number of folks who simply will not be on Medicaid anymore due to work requirements and that other regulation that's hanging out there.
Which we will address that in a few weeks, I believe, the work requirements issue. Right. Yeah. So Medicaid already is chronically underfunded. This proposed rule will underfund it even more. And then you add the fact that I believe CBO thinks 11 million folks will leave Medicaid because of the work requirements issue. In other words,
yes,
that is a dramatic change in the Medicaid landscape for all AMGA members.
This is a perfect storm, right? I think we know how that movie ended.
Great movie. But no, it's true. This is that's why AMGA is fighting the Medicaid fight, I think, fairly aggressively.
Yeah.
Both in Congress as well as with you on the CMS front. Okay, so CMS is proposing to extend the Medicare-based limit to all state-directed payments, not just the 4 service types Congress specified in the OBBBA. What is the significance of that expanded scope as far as CMS is proposing?
Sure. This was really aggressive rulemaking on CMS's part. So the underlying statute named 4 service types, inpatient hospital, outpatient hospital, nursing home, and academic medical center practitioner services. This proposed rule extends those same limits we've been talking about to all state-directed payment arrangements and all service types. So instead of this 4, even though those are like, I hesitate to call inpatient hospital services narrow or outpatient services narrow. This is going well beyond what Congress explicitly required. And CMS's justification here is they're framing this, this broader scope as consistent with President Trump's Medicaid integrity memorandum that he put out a couple months ago. And so it's just not just this narrow or statutory mandate. They're definitely looking to fall back on that. We are going after what we consider waste, fraud, and abuse in the system. And this is the, instead of a scalpel, this is the, battle axe that we're taking to, get this under control.
It's interesting. We spoke in the last 2 episodes around regulations. CMS has a very clear, we think, concept of where they want to move, whether it's fee schedule, whether it's the OPPS and ASC proposed rule, or now Medicaid state-directed payments. They are trying to reduce costs wherever they can.
Yeah.
We talked last podcast about leadership at CMS wants to use the program as a deflationary instrument, and it seems like that's what they're doing here as well. I mean,
it's right in the rule. Like, so when CBO scored this provision for One Big Beautiful Bill, I think it came in at like $150 billion, right? By expanding the scope of services that are going to get captured under this provision, CMS's own estimates like $510 billion through 2035. So it's dwarfing what CBO originally estimated. I think this is going to be. I would anticipate this is going to be one of the most focus or emphasis in comment letters on this, like since it goes beyond the plain text of what Congress actually
really
passed. And I don't know, like, again, I hate making a legal argument here, but is there a legal challenge here because it goes beyond what CMS said, or I'm sorry, what Congress said?
Yeah. Well, a couple thoughts. One, so they're estimating over a $500 billion cut because of this proposed rule over till 2035, above the $150 billion which CBO initially projected. That is an increase of $350 billion. So now we're talking about cuts to Medicaid almost approaching $1.4 trillion if this rule went in as proposed. And to your point about going beyond the statute, there was a court case. Oh my gosh, I was a former lawyer. I believe the Supreme Court actually sort of limited what agencies can do unless it's specifically tied to what Congress said in the statute. Or it could be the opposite. So don't quote me on that.
They wanted Congress to be more prescriptive.
Right.
It was what is that legal? Oh, jeez.
Another MVP issue. Yeah. So we're killing it over here at AMGA.
I mean, I didn't go to law school. So.
Yeah, well, I have 2 law degrees. So one in health law. So shame on me. But I do believe, legally speaking, you can use that Supreme Court decision.
Yeah.
Say, look, you are going well beyond the clear intent of Congress.
Right.
And these cuts are not appropriate.
Yeah.
So all right, and these not these cuts, but rather the proposed rule is
and
beyond what
the scope of services that are getting captured.
Congress intent. All right, well that of course is TBD. Lawyers are doing very well.
Yeah.
Under this administration, because lots to litigate. Okay, so states have built their entire financing strategies around provider taxes and SDPs. How disruptive is this going to be if it was finalized as proposed?
Yeah, incredibly disruptive. I think, like you said, many states fund their non-federal share of their state-directed payments through provider taxes or integral transfers, and this is the exact mechanism that CMS has flagged as potentially enabling arrangements that are financially advantageous to a select number of small providers. So a shift to these, Medicare-based limits could reduce the total dollars flowing through these arrangements, even though there's some grandfathering and phase down and all that. I think states with a significant number of large academic medical centers or safety net hospitals that rely on these state-directed payments that are, pegged to that, those commercial rates are the most exposed, since those payments tend to run well above Medicare rates. And states, the state legislatures are going to need to get involved, and they're going to need to, renegotiate how these work, or the state Medicaid agencies are going to need to renegotiate their financial structures with, their hospital and academic medical center partners before this phase down is fully implemented. I think, we've sort of emphasized that this hits on, systems, the academic medical centers, state and hospitals. I think physician groups are exposed to this as well, depending on their Medicare population. So this is going to be broadly felt across the healthcare system. You can't pull this amount of funding out of the system and not expect some really dramatic impacts.
Yeah, and I agree. Well, relatedly, so what is AMGA going to say about this proposed rule?
Yeah, so we really hit on the access issue in our comment letters on
access.
This.
Okay.
Access. So if you are going to cut Medicaid by a significant amount, and then we'll talk next time about the coverage restrictions for Medicaid patients. So you've got these concurrent things going on just in the Medicaid space. You're reducing the amount of dollars flowing into the system, and you're reducing the number of folks who actually qualify for coverage. So I think our members would argue limited coverage, or coverage that maybe doesn't cover the full cost, is better than zero coverage. So there's that. And we had we pulled from our Medicaid survey data to help bolster our arguments in this letter. And we hit on our members are considering or have closed down service lines or clinics. They're going to start furloughing staff.
Yep.
Like, there's a whole lot of problems that are going to be the direct result of fewer dollars flowing through the Medicaid system to help help our members cover their expenses.
That's right.
The other thing we hit on in our comment letter related to this access is there is no again, I delving into lawyer speak here a little bit. There's no private right of action. Like, Medicaid beneficiaries can't sue the government because they don't have access to care anymore, right? CMS is the sole determination of whether or not they are meeting the statutory requirements of having meaningful access to care. So the Medicaid statute requires CMS to both be like a prudent spender. They have to take care of the taxpayer and spend their federal tax dollars appropriately, but they also have to spend enough to maintain access to care. And they didn't really provide they did not provide an analysis of what this will do to access in this rule. So I'm concerned they are ignoring half their statutory requirement here. And if this has significant access issues, it's incumbent on CMS to recognize that and adjust accordingly.
Okay. And so we are going to ask CMS, or point out the fact that they did not comply with half the statute, that they need to talk about access as part of this proposed rule, not just go for the efficiency argument,
right,
as well as the prudent use of federal funds part of the statute, which makes sense. Yeah, and Daryl, you mentioned our Medicaid cut survey. We've done 2 in a row, and yeah, the members paint a very bleak picture. If I remember correctly, some of the figures, 38% of the respondents this year said they've already eliminated some patient services.
Yeah.
68% said they're going to eliminate services next year, when the first real set of Medicaid cuts goes into effect, which is the work requirements rule, which we'll talk about in a couple weeks. And you mentioned also there will be closures,
yep,
particularly of rural hospitals. But there's also a lot of discussion around eliminating services around pediatrics, maternity, and behavioral health.
And that's what Medicaid pays for, right?
Indeed. And those are the services that you absolutely need to have. Yeah. Otherwise, what happens is those people show up at the ER sicker, and they'll be placed in a higher acuity level, which is more expensive.
It's more expensive.
So really not well thought out at all. And the survey helps show that, I think. I know we've shared that survey with Hill staff, and I know it was viewed with alarm. And it's something, so I know this is a regulatory podcast, but legislatively, we will be hitting on this issue. We already are. Yeah. And we're doing it now. We're laying the groundwork for possible changes in 2027, but the survey data is absolutely going to help us. And to the members out there, when you see the survey, which we'll probably put out in the spring, please answer it, because it's the data that actually moves the policy. So that would be great.
Exactly.
Fantastic. All right, I think that's about it.
I think we're done here.
Yes.
This is Medicaid. We took this. We saw this very early on as they were drafting One Big Beautiful Bill, and I think we were one of the groups that recognized early on how significant of a problem this is going to be for our members. And I really think that access to care issue is going to be a serious problem if they don't address this.
All right. Thank you. Well, we have our work cut out for us. We have Medicaid cuts. We have physician fee schedule issues. We have the OPPS and ASC. So you're very busy.
Yes.
I know the team Ledge, Lauren, Jamie, and Alicia are busy, which I guess that's good. But we have important issues that we need to succeed in. And to the members out there, we need to work with you on all these things. When we work together, that's how we actually move the needle. So look forward to all that. And with that, Daryl, thank you for 3 weeks of regulatory-only podcasts. You nailed it. Appreciate all the work. And
I'm looking forward to our second trilogy now.
That's Mike, and I just sort of nodded no. But it was well done, and thanks for all the work. Mike, thanks for producing. And for everyone else, hope you all have a very good day.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.